Good afternoon, everyone. My name is Tara Britton. I'm the Director of Public Policy and Advocacy with the Center for Community Solutions. Welcome to our second webinar on the state budget. This one we're reviewing Health and Human Services in the House-passed version of the state budget. I'm going to give it just a few seconds before we jump into the content to give folks a chance to log in. But I will start going through a few of the webinar logistics. Everyone, as they've joined the webinar, has you all on mute, and please provide feedback in the chat bar. We do have someone kind of tracking those questions as they come in, so we'll try to answer those as we go through the webinar, but then there's also a chance for questions at the end that we've left time for, so you'll have plenty of opportunity to ask questions. The slides will be shared with all of you after the webinar. We'll send those out in a PDF format after the end of the webinar. We are recording this webinar today, so if you're not able to stay for the whole thing or you have colleagues that are interested but weren't able to make it today, this will be posted to our website, and then we'll also send it out in our email that goes to our listserv on Thursday called the Weekly Briefing. Just so you all know, we have a great, vast social media presence through a few different Twitter handles at Community Solutions, but if you would like to follow us at CCS Policy and also at Community Solutions, it's at Community Sols, S-O-L-S, actually. You can learn more about all the work that we're doing related to the state budget and lots of other things, but that's a good place to track the work that we are doing around the state budget. So let's jump into the content. So we're just going to recap. We did this on our last webinar, so for those of you who were there for that one, this will be a refresher, but also just wanted to provide this information so that everyone can kind of see where we are in the state budget process. So this is the process in as much as we could get it into visual format. So we are now through the House process. So that first column on the left, we have completed that. The House passed its version of the state budget in early May and sent it formally over to the Senate. The Senate is now hearing the bill in what we call the subcommittee processes. So the Senate Finance Committee is the main committee where the budget is heard, but they deal with the budget in different subcommittees related to different topics. So health and Medicaid is one, higher education is another, primary and secondary education is another. So, you know, just dealing with a really vast policy document takes a lot of time to really dig into it, so that's why they take each section of the budget and kind of deal with it in subcommittees to hear testimony. That testimony is still ongoing in the subcommittee process this week. We're hearing kind of different things that the subcommittee process may finish up this week, could be next week, but it will be soon. And then the budget will head back over to the full Senate Finance Committee for the Senate Finance Committee to make its changes, and then it will be reported out to the full Senate for a vote in early June. As it moves out of the Senate, it moves into conference committee to deliberate and agree on the changes between the House and Senate versions of the budget. That will happen in mid to late June, and then once those changes have been agreed to on both the House and the Senate side, it will go to the governor for his signature, which has to be done by the end of June. So that's the process, kind of where we are, and you know, you'll get an update on this as we're planning to do a webinar on the Senate version of the budget, and then also one when the budget has been fully accepted and signed, and we know everything that's in there and will guide us for the next few years at the state level. So moving into the different areas of the budget. I'm going to start off with what happened between the governor's introduced version and the House-passed version in the Ohio Department of Health. So this slide may look familiar to those of you who were on our last webinar. These are kind of the big areas that were dealt with in the the budget as introduced, what the governor proposed and what the House passed, there are some pretty significant differences between the two budgets in the Ohio Department of Health area. We talked a little bit about how the governor's budget was introduced kind of with this framework of the State Health Improvement Plan, which is an actionable plan to improve health and control healthcare costs. So that kind of is the view by which the budget was presented in the Ohio Department of Health, really looking at population health and how to make large improvements there. This is still integrated into the House version of the budget, and really, continues to look at large population health efforts around a few different areas. So moving into kind of the content, looks at lead-safe residential units, which I will talk a little bit more about as I get into other slides. There's also continued efforts to combat infant mortality. One big change between the governor's budget and the House-passed budget as it relates to the Department of Health is that the governor's budget proposed to make major changes to the Bureau for Children with Medical Handicaps program, and that those changes have been reversed. So essentially we're going into, or we're now in the House-passed version of the budget with the Bureau of Children for Medical Handicaps restored. The funding for that program is restored and will stay within the Department of Health as it stands in the House-passed version of the budget. And then there are some efforts around local health departments that some of the funding was changed a little bit in that space as it relates to the House-passed version of the budget. So I will jump in a little bit more detail to these other areas. So as it relates to lead abatement, lead remediation, these are some of the major changes in that space. So the governor's budget did include basically a proposal that the Ohio Department of Health and the Ohio Department of Medicaid would work together to leverage funding, federal funding through the Children's Health Insurance Program to get $5 million in each year of the budget to work toward remediating lead in houses where children lived. And that component of, as it relates to lead, still remains in the House version of the budget. What was added was some language around how lead remediation works and where the authority lies. So that's one big change related to lead. As I mentioned, as it relates to the Bureau for Children with Medical Handicaps program, or BCMH, that program has been fully restored and is now going to, as far as the House budget is concerned, going to stay the way it exists right now. It will continue to live at the Ohio Department of Health. The case management will stay in place that occurs with the public health BCMH nurses. That was a big, you may have heard things in the media about this program and the potential changes that were proposed there around, moving part of that program to Medicaid and using Medicaid case management for these children that have really high health needs, high cost, and high intensity health needs. So that program will, remain the way it exists as of today. It remains to be seen kind of what happens in that space in the Senate. We'll certainly update you around that. One piece I wanted to highlight in terms of changes between the as introduced to the House budget. You may have heard a lot around the revenue estimates and how revenue estimates are coming in lower than expected. The House and Senate leadership joined with the governor and the governor's budget director to essentially, they held a press conference and talked a lot about, how revenue projections were coming in lower, and this was something that was going to have to be dealt with in the budget process. So, we don't have as much money to work with as we thought we did. And so as a result, there were many line items within the entire budget, not just as it relates to the Department of Health, that, I think some deliberation went on around what line items could sustain a 1.5% cut. So there were several line items throughout the entire budget that if, it was kind of determined that they could sustain a 1.5% cut by those deliberating on the House budget, that cut was applied to that line item. Unfortunately, I think we are concerned that even a small cut could undermine some things that are happening, some efforts specifically around infant mortality. So this is one space that we're starting to really make progress on in the state of Ohio, and there was a 1.5% cut applied to the infant mortality line in the Department of Health budget. So we'll see what happens with that in the next round in the Senate. There was a larger cut to HIV prevention, which we want to bring to your attention as we don't receive as much federal funding for HIV prevention as we do on the HIV treatment side, but ultimately, we want to get upstream on the prevention side and really help prevent HIV in the first place. So pulling, flexible state dollars out of HIV prevention is something that we're going to continue to monitor. And then I mentioned the local health departments and what's going on there. So what the governor's budget had proposed in that space was to any local health department that has achieved accreditation or is on their way there and will achieve it within the next few months or years, we're going to begin to be eligible for increased state funding. There is an overall requirement that local health departments become accredited by 2020. That has been ongoing at the state level for a few years now during the Kasich administration. And there was a reduction in the line item for local health departments. So those that have become accredited will still be eligible for increased funds in the next few years, but that kind of remains to be seen how that will play out, specifically now that line item has received some cut in the House version of the budget. So I'm going to talk just really briefly a little bit more about this, the changes in the lead remediation space, because I know this is something that has also been in the media, and I just wanted to bring to everyone's attention. So as I mentioned, the changes that were proposed around lead remediation in the as-introduced budget. So I've kind of identified that here, that the Department of Health and Departments of Health and Medicaid were going to seek federal CHIP funding for lead abatement, and then also create a lead-safe housing registry. So this was in the proposed budget. It remains in the budget. What has been added in the House-passed version of the budget is the authority for lead abatement. That authority would lie entirely with the Department of Health. So I think, what we've heard around this, I say we kind of collectively, that we've heard in the media is that, this has a particular impact on Toledo and the efforts they've made around lead abatement in the community, and also impacts what may be done in Cleveland and other cities in the state that look to work on lead abatement in their cities or regions. So I think this is certainly something that we'll continue to monitor in the Senate and see what the Senate does in this space. I know that Senator Lehner in the Senate, Senator Peggy Lehner is looking to make some changes in this space. So I think stay tuned on this. I doubt we've heard the last of kind of the changes around this issue. So that kind of covers the big changes in the Department of Health's budget. I'm going to move into mental health and addiction services. You've likely heard a lot about that the Ohio House had big plans around combating the opioid crisis. This deals with not just the opioid crisis, but kind of behavioral health in general, as we work work to really inject some resources into communities around the state to address the opiate crisis, but really, I think, get kind of further upstream in a lot of areas in terms of prevention and also being able to stabilize people in crisis situations. This is an area where, as I said, we had heard that the Ohio House was planning to inject significant dollars. So what this comes out to is about $170 million of investments over the course of the biennium. So that's over the 2 years. The plan that the Ohio House put together is the Ohio Hopes program. So what this does is kind of breaks out into different buckets the investment areas. And I won't go into extraordinary detail on each of these because it's a lot. There's a lot here. It's also not necessarily clearly spelled out. It's not a line item by line item that each of these initiatives that's included in the Hopes plan kind of has specific dollar amounts attached, and they're all in their own line item. So it is a little bit of a puzzle to piece together where all of this money lives, but it really is across agencies. It's across mental health and addiction services, higher education, job and family services. So the money kind of lives in a couple of different places and will also flow in different ways. So some of this, does directly go down to the local level in the form of, the increased funding for child protective services. They're also looking to invest in community coalitions in every county around drug prevention. So, that will flow directly down to the local levels. There's also examples here of leveraging federal dollars, so putting in a state investment in order to draw down some federal dollars. That would be in the form of the SNAP workforce and training funding. So like I said, I'll highlight a few of these, but not go into extraordinary detail on all of them. So I kind of touched on the workforce piece. That's also in conjunction with the Department of Higher Education. So getting some short-term certificates that people can go through some training and get certificates in in-demand jobs. So that really helps connect people back with the workforce. In the prevention space, like I mentioned, the community coalitions, that will be money that goes down to every county, a county hub to combat opioid addiction. There's also, in this area of prevention, a partnership that the state is working on with the Ohio State University in terms of an app and a website that are readily available to people to learn about, kind of ranging from prevention to treatment opportunities to just kind of general educational resources around drug abuse and drug prevention. In the mental health space, that is, kind of a mix of things related to the drug lab reports are actually through the Attorney General's office, and this is to make sure that investigations related to opiates, there's enough resources there in order to complete those. The mental health stabilization centers, that's a pretty large investment that these stabilization or crisis stabilization centers will be created in each of the 6 state psychiatric regions. Telemedicine coverage relates to making sure insurance companies are covering behavioral health telemedicine services, kind of on par with other things, and that's been a push over the last few years, especially to bring access to rural areas. The drug court pilot program, this is actually one bullet point that there's some debate over whether this belongs in mental health or the treatment bucket. I think, probably more so in the treatment bucket. But this is really just an expansion of an existing program that allows people involved kind of in the criminal justice system who are addicted to drugs but are not, violent offenders to kind of direct them to treatment rather than kind of through the traditional route of the criminal justice system, which is similar to, there's also going to be a pilot program related to mental health drug courts, kind of the similar setup. As it relates to treatment, this is kind of the largest bucket in terms of dollar amounts. As I mentioned, here's an influx to child protective services, as we've all heard a lot about the impact that the opiate epidemic has had on child protective services and how, many more children are ending up in custody because of parents or guardians' drug addiction. So there is a large investment here. There's an investment in transitional housing for people coming out of recovery services. There's a pilot program related to using nursing home beds for substance use disorders, so that will be interesting to hear more about. And there's additional dollars going to ATOM boards, so here's another example of dollars flowing to the local level, some of which is determined based on kind of each ATOM board is getting a designated amount, but then also additionally looking at the number of opioid-related deaths in each region, and then there are dollars kind of associated with that and a formula that will be developed. There's an influx of funds for kinship caregiver support. So these are, grandparents or other relatives who end up in, kind of the unfortunate situation of having to take care of children in their lives because of drug addiction. So there is additional funds there. And then in terms of expansion of treatment and detox, this actually relates to kind of investment in capital costs. So taking existing spaces, many of them state-owned, and kind of transitioning them into treatment facilities so that we can expand treatment in that space. So a lot there. Another big change in the behavioral health world, and I'm kind of moving into the Medicaid realm, so in a minute here I'm going to turn it over to Lauren Anthus, who will cover the Medicaid portion of the budget. But just to let you all know, related to behavioral health redesign, so this is the state's effort to make coding changes and add additional services to the behavioral health package before the behavioral health services, the community behavioral health services, are moved into Medicaid managed care. Essentially, the big change here is that implementation of each component of redesign has been delayed by 6 months. So instead of the coding changes and additional services coming online July 1st of this year, they've been pushed to January 1st of 2018, and then it has a subsequent 6-year push of from January to July of 2018 to carve the services into Medicaid managed care. So those are the big changes in the Ohio House passed version of the budget as it relates to health and mental health and addiction services. And then I am going to turn it over to Lauren to look at the Medicaid changes.
Thanks, Tara. So I'll try to cover some of what we're seeing in the Medicaid portion of the budget. And I want to focus on a few key areas. First, long-term care, then what's going on with hospitals, seeing as hospitals represent about 1/3 of all Medicaid dollars that flow through the state. This push for greater legislative oversight of the program, so that's a trend that we saw through the House process, and then a little bit on the waivers that are being sought by the House. This is a continuation of some of what you may be familiar with in terms of personal responsibility, and then some additional pieces that we advocated for, as well as some other conversation around things like inpatient-based behavioral health treatment. So moving to long-term care first, like the behavioral health redesign delay, we are seeing an effort to delay the Medicaid long-term services and supports system, sort of the carving in of long-term services and supports into Medicaid managed care. We're seeing a delay until 2021. Included in that would be the establishment of a study committee to review the carve-in, and that study would be due on June 30th, 2020. There is a number of organizations that are cited that would require representation, but essentially what you've seen here is a strong pushback from the long-term care industry and other organizations and interests in the privatization of that element of the program. Obviously, the state has an interest in the privatized model of care delivery. This is something that they have valued over time. You've seen additional carve-ins over time. So this was sort of the first, or rather, if you think about behavioral health as well, the second sort of push against the administration's efforts in this area. So it'll be interesting to see where we are. I will note here when we get into the nursing facilities portion here that there were increases for nursing facilities in particular. Now, something to understand about the nursing facilities that operate in Ohio, first of all, they're the only provider type with the rates established in Ohio Revised Code. So other provider types have their rates determined in rule, so it's a process that is largely controlled by the department. And you see that essentially the rates have increased about $307 million, which is roughly $113 million state share over the course of the biennium. And then there was a delay, or rather a sort of truncating of the time period in which the state could collect overpayments from 5 years to 3. Oftentimes, the state tries to do audits and for the purposes of, say, their fraud and waste efforts, try to make sure that when they're examining claims, they can claw back some of those funds. And they have up to 5 years right now at nursing facilities. That has been drawn down to 3. I will say that this is probably an area that's going to receive a lot of attention, at least politically. The elderly are the fastest growing demographic in the state of Ohio. Nursing facilities are quite a large industry. And there's been a lot of conversation around quality in nursing facilities here in Ohio. At Miami Scripps Gerontology Center, which is sort of known as one of the best resources for information on Ohio's long-term care system, released a study showing that Ohio is below average on nursing facility quality measures used by the Centers for Medicare and Medicaid Services. All the data is from 2013, so there is a lag there. And they showed in that study, too, that nonprofits tended to have higher quality than for-profits in terms of their overall star rating. You've seen some positioning by both the industry and the administration around this issue relative to payment and to quality. The administration has said and has made recent efforts to demonstrate how the way that we reimburse for nursing facilities currently does not incentivize quality. I will highlight the fact that in statute there are quality add-on parts to the nursing facility reimbursement structure. But there essentially isn't a lot of flexibility there. So the administration, number one, wanted to take it out of statute. Number two, wanted to privatize the delivery system. And number three, sought to sort of have greater oversight over the rate construction. And this was essentially reversed in the House, and I imagine this is going to be an area of great concern in the Senate, not only because of the amount of dollars that we're talking about, but also because of budget timing. Oftentimes when you talk about transitioning to Medicaid managed care, it affects the way in which you can manage your cash as the state. So there's a lot of concerns there coming from the administration. It's going to be an area of focus. I'd also want to highlight that it eliminated rate increases for home and community-based services. So one of the things that we've seen over the course of the last decade or so is a transition away from facilities and institutionalized settings into home and community-based service settings, which rely on Medicaid waivers, basically getting out of places like nursing facilities or other long-term care facilities and moving into home and community-based settings. And the administration had proposed rate increases for those providers, basically to provide incentive for those settings to be, more prime in the minds of providers over institutionalized settings. And those rate increases were eliminated. So this entire space of long-term care, I think, is up for grabs as far as the dialogue, if only because there's a lot of money, but we should expect a lot of movement there. Moving on to hospitals. So hospitals initially were facing some level of a rate cut from the administration's proposed budget, and those rate cuts were eliminated, and instead there's a proposal put forward that says there's a ceiling for hospital payments of around $6.9 billion, and once the providers hit that ceiling, rates will be reduced if those payments exist that amount in either fiscal year. So essentially the rates are sort of held harmless until the point they hit that ceiling. I guess the question becomes, at what time would the providers hit the ceiling, and what's the incentive to stay below that ceiling, and how does that compare to what the rate cut would have provided? Secondarily, the non-contracting provision has been eliminated. So this is, if anything, another tradition of the Kasich administration, like nursing facility rates in Ohio Revised Code. Essentially, it says that if you're a hospital, that you have to accept the fee-for-service rate, so the rate that would normally be paid in fee-for-service as opposed to managed care, if there's no contract between the plan and the hospital. Right now, That's not necessarily the case. So this would certainly provide more pricing and contractual leverage for the managed care plans. This elimination cost state relative about $262 million, which is a roughly $81.4 million state share. So this is something that will continue to be part of the dialogue, though this particular piece has shown up in multiple budgets and have not yet made it all the way through. And then in somewhat of a surprising move, and I include this in hospitals, although this extends far beyond hospitals, is the elimination of the Comprehensive Primary Care Initiative, or CPC. This is a process that seeks to try to reward mainly primary care physicians and practices around lowering costs and increasing quality. And the CPC is sort of the second element of the state's efforts behind the State Innovation Model, or SIM grant model, which tries to move down the direction towards value-based reform. The second piece being episodic-based payments. The episodic-based payments were not touched, but CPC was essentially eliminated, which may compromise Ohio in a number of ways. Notably, it would sort of reverse this trend over the last couple of terms of the Kasich administration towards rewarding on value, and then there's the potential, too, that the federal government would want to see the grant dollars it's already obligated to come back. So that might cost the state of Ohio some money, and it also doesn't address what happens with episodic-based payments, which is supposed to communicate, if that makes sense, between the program that's operated in hospitals with episodes and what happens at the primary care office level. I imagine that in some form that CPC will probably make its way back in the Senate, if only because the elimination actually costs some money. So moving forward, want to talk about the push for more oversight. So that graphic on the right is intended to look really complicated. The reason is that's just a page inside the rate book that exists in the Medicaid program, and it's actually, ICD-10, the coding system behind most medical care. It exists across Medicaid, Medicare, private insurance. There's roughly around, I think, 150,000 different codes that are associated with delivery of medicine. And part of what the state or what the House did is that they wanted more oversight of rates. And so essentially JMOC, or the Joint Medicaid Oversight Committee, would review the rates that are submitted by the department's director. So right now the director has sort of the authority to develop rates as they see fit in order to manage the program appropriately. And now JMOC would essentially have the ability to veto any changes that would happen with rates. This would be a pretty cumbersome process for most directors, and it might hinder the director's ability to stay flexible within the program, if only because it's often a very complex process trying to manage the $48,000 a minute that gets spent in the Medicaid program. But also, it might open it up to a little bit more special interest influence. So depending on what rate set you're talking about, you might have more people trying to go to the legislature to try to manage that cash, and especially in a time when a lot of the policy dialogue is around controlling costs, this might make it a much more cumbersome process for the department to try to enter into. Additionally, eligibility for certain groups would then be subject to legislative authority, or rather statutory authority. So with Medicaid expansion, for example, for those of you who know the arcane sort of detailed Medicaid issues, the director had the ability to opt into expansion. The question was really whether or not the funding would follow to provide coverage to that group of individuals. This would remove the authority of the director to do that through the state plan amendment process, or rather the contractual process between the state and federal governments, and instead would say that the General Assembly would need to establish in Ohio Revised Code what groups are to be covered or are able to be covered by the Medicaid director. Again, this gets into the issue of flexibility and may hinder the director's ability to be responsive to economic conditions. Medicaid is known as a countercyclical program, which means that when the economy is worse, you tend to spend more. So without having the tools around things like eligibility and rates directly under the control of the Medicaid director, and instead under the control of the legislature, that just might make it a much more difficult program to manage. Another piece here is around the controlling board. So this is interesting, if only because there has been a lot of conversation around the appropriateness of the controlling board in determining Medicaid funding decisions, but the House seemed to include more authority with the controlling board over Medicaid decisions. So first, when it comes to the budget overall, the director must request funds from the controlling board to pay for all Medicaid expenditures. So, and this happens at least every 6 months, but no more than every 6 months. And this would affect the entire Medicaid program. So we're talking about nursing facilities, addiction programs, DD programs, mental health services, and potentially they're in jeopardy of losing funding twice a year. And the requirement will make it challenging for ODM to then enter into long-term contracts, which would likely drive the price of services higher than they would have been otherwise, if only because much of the program is privatized and relies on contracts, and so those entities that enter into arrangements with the department would have less guarantee that there's a long-term sort of stability to what's going on. And then there's potential conflict here because there's new language saying that there's somewhat limited approval for departments in terms of their funding request to $10 million or 10% of an agency's budget, whichever is lower. So 10% of Medicaid spending is roughly around $2.5 billion. So that's definitely higher than $10 million. And what's highlighted here in the controlling board authorization, if you just look at the comparison document, we're talking potentially around $60 million a fiscal year. So I'm not sure how these two comport with one another. So it's also going to be confusing as to how these two issues resolve. And then lastly, there's this approval, this approval process by controlling board is contingent in part on satisfying, quote unquote, multiple waiver processes or requests. So there's a number of waivers that are highlighted in the House version of the budget, whether we're talking about personal responsibility, workforce requirements, an Imd waiver. So this becomes much more subjective. So what does satisfaction actually mean in the context of a controlling board, and how does that work with federal oversight process? Because waivers and the accomplishment of waivers take some time often. You have to develop it, you have to write it, you have to go through a public hearing process, you have to collect those comments, reflect them back to CMS, so on and so forth. So how do those two timelines meet? And then two, with Medicaid, since these funds are really tied to GRF, and we're talking about a matching process or reimbursement process, do you even really need to go there every 6 months in order to draw down the funds, or could potentially the department wait to some point when they hit the need? So that complicates things greatly. So there's a lot of confusion around this piece, but I think that the Senate would have to try to sort of go through this language and make sure it's not as vague, and also I think it brings into question how the program would actually work. Beyond that, to talking about waivers, so first there's the sort of Healthy Ohio Part 2 section. So one of the things that must be approved is sort of Healthy Ohio Part 2. This is already in statute, but essentially is this cost-sharing individual responsibility waiver that talks about the establishment of co-pays for the program. There's the point system. We've written a lot about this on our website, so I won't go through detail here, but that's a renewed sort of effort. Then also there's the 1332 component. So in the last budget, the General Assembly required Ohio to pursue a 1332 waiver, which is something that's embedded within the Affordable Care Act that is focused in on the marketplace, so not Medicaid, but the marketplace, even though the Medicaid funding is somehow tied to the approval of this waiver, which is interesting. But essentially would allow the state to change the requirements of the plans that operate in the marketplace, change how the marketplace operate themselves, change the credit process and cost-sharing process, and change or even eliminate the employer and individual mandates. The Department of Insurance did not pursue this, so the Medicaid funding being tied to this and the requirement that the state of Ohio pursue it is interesting, and could be an area of fertile conversation moving forward, because I think in the minds of many legislators, they see all these issues as being tied in together. There's also sort of a work requirement piece. So on work requirements, it says that if you're going to be a part of the Medicaid expansion group, that you have to be employed essentially. And there's other sorts of exemptions for individuals, such as are you 55 or older, or do you have some other sort of qualifying health condition. But on work requirements, research indicates that people who are on TANFs and not subject to work requirements saw their employment rates rise in the long term, even as the people with work requirements lost jobs. And the few work requirements that did have some enduring effects, like those in Portland or other communities in California, were often tied in with strong training, subsidized work, and placement programs. None of that's really identified in the language of the legislation. I would also point out that in the Medicaid, about 87% of the able-bodied beneficiaries were working, are looking for work, or in school, and 43% actually in the Medicaid expansion alone have indicated that they are currently working. So of the remaining 13% too, so 87% are working, looking for work in school. Of the remaining 13%, about 9 or 10% of them are not working in order to take care of family members, or have just been recently laid off. So there's potentially a lot of negative outcomes to this, and I would say that this would disproportionately negatively affect rural counties. We wrote about this recently, and you can see that in rural counties that are disproportionately benefited by Medicaid and seeing the economic benefits of those dollars also tend to have higher unemployment rates. So, what are you supposed to do if you're in a rural county where there aren't really that many jobs available, and maybe the only jobs that are available are at clinics? If you somehow diminish the amount of Medicaid resources, what happens economically to those hospitals, to job opportunities, to coverage generally? So I think that that's an ongoing conversation that needs to take place, and we've obviously advocated for some of the stronger pieces around medical frailty to protect individuals from some of these requirements. And medical frailty, as is the case with Indiana, with a similar model, includes things like cancer, victims of sexual assault, things like that, who for no fault of their own may not be able to achieve some of the requirements that you see here in Ohio's currently proposed program. And then last piece here is around an Imd waiver, and this is much more complicated. So this is a waiver and let me backtrack for a little bit. Medicaid historically has not paid for inpatient behavioral health services for a couple of reasons. One is cost, and then the other is institutionalization, because there's a concern out there that just institutionalizing individuals with behavioral health needs is not necessarily a good idea. Research suggests that in terms of cost, it would take about $40 billion to eliminate the Imd exclusion over the next decade. There's other concerns if you do this sort of exclusion process where there might be some more reinstitutionalization. I will highlight the fact that the state of Ohio is already moving on some coverage of inpatient behavioral health services. So last year, the federal government put out rules with managed care that suggest that individuals who have inpatient behavioral health needs are able to receive Medicaid reimbursement for those services up to 15 days in any given month, and can actually receive 15 days back-to-back in 2 months. So that might relieve some of the pressure as long as it's connected to community supports, and we're going to see more from the state around this issue. But the Imd waiver is an interesting piece, if only because there's certain requirements around budget neutrality, and oftentimes in other states that have pursued this, it's often expensive, and then obviously there are some concerns around that institutionalization piece. So a lot of moving parts, seemingly in the same subject area, but not necessarily connected more formally. So with that kind of covers where I'm at with Medicaid, and now I'll hand it over to Bree Leshik to cover the remainder of our presentation.
Thanks, Lauren. Good afternoon, everyone. I'm going to be finishing up on the Health and Human Services agencies, specifically provisions as passed by the House version dealing with aging, developmental disabilities, and job and family services. So starting off with some aging provisions, Adult Protective Services funds were increased by the House by $250,000 per year. This is a 9.47% increase from the as-introduced version of the budget. And additionally, there were some APS provisions added specific to memorandums of understanding, removing that requirement from law, codifying the Attorney General's Elder Abuse Commission. The current version of the budget expands mandatory reporters to include individuals in the financial sector, makes various changes to some definitions, specifically caretakers, the word neglect, and exploitation. Some of these are quite controversial, and there's been talk going as as House Bill 49 moves through the Senate, some talk among senators about possibly moving this language out, the additional APS provisions, and looking at that in specific legislation. I know that Senator Wilson is working with some of those financial reporter terms and whatnot. So we'll see if this stays in there in the Senate. Additionally, food banks had a $1 million cut over the biennium. 18% of food bank recipients are seniors, so we're going to be following that closely as the bill moves to the Senate. Additionally, assisted living changes. The as-introduced version of the budget permitted the created new rate settings that were anticipated to be about $34.9 million in fiscal year 19. The as passed by the House version prohibits these changes. And likewise, the personal care aid restrictions, the as passed by the House version prohibits rate increases for personal care aids. Additionally, there was a cut to the senior service block grant. The House cut about 1.5% of this in each fiscal year. This is pretty significant to the additional cuts that have been seen declining from this fund over the past 15 years. Ohio Department of Developmental Disabilities. The as-introduced version of the budget saw increases to ICF and IID waivers. Those increases would have manifested to be about 1,300 state finance, home, and community-based waivers, as Lauren kind of touched on a little bit earlier today, so I won't dive too much into that. As the director was testifying before the Senate Health and Human Services Finance Subcommittee a few weeks ago, he did mention that this remained a top priority for the agency in addition to workforce. The as passed by the House version of the budget makes changes to the law regarding waiting lists. There is an change to form a study committee to examine waiting list procedures. This will assist the state engaging the needs and limitations of the some 40,000 Ohioans that are currently on the waiting list. Help Me Grow will have a clear distinction between the DODD and Department of Health. I say clear distinction rather lightly. This was a change that was changed in the last MBR. And what now will happen will ODH will be the lead agency to oversee the delivery of home visiting services, while the Ohio Department of Developmental Disabilities will be the lead agency to oversee the delivery of early intervention services. As I kind of touched on, this was a change in the last MBR to kind of combine these together. So the House chose to kind of revert back to where we were about a year ago. We'll see what the Senate decides to do with that. I know that a lot of individuals thought that this would kind of make things messy, as there's a lot of those changes have already taken place from the MBR. The wage increase for direct support staff that was in the as-introduced version of the budget was removed. In addition to the administration's proposals around ICF, IID rates. The fiscal effect of this in the as-introduced version would have been about a 2.5% increase in the fiscal year 19. There was not going to be any changes in fiscal year 18. Moving on, last but not least, to the Department of Job and Family Services. Tara kind of touched on some of these in the HOPES agenda, so I will just briefly touch on them. There was a $10 million increase in each fiscal year for kinship care. This will come from TANF and will help alleviate the burden on families who are taking in a large amount of children due to the opiate epidemic, and that's in addition to the Family and Children Services $8.8 million increase to provide $100,000 to each county JFS. Additionally, $150,000 in each fiscal year will be provided for children's crisis care facilities. Among infants in care, 70% are there due to their parents' opiate addiction. Ohio Department Job and Family Services Directors Association mentioned that in testimony before the House Finance Committee. So the opiate epidemic is really taking a toll on the state budget as far as children's services. So these will be welcome impacts to that. Funding for the extension of foster care and additional resources for adoption. The federal foster care line item saw an almost $20.9 thousand increase in fiscal year 18 and maintained that in 19. The House did maintain the administration's asks on these. The Healthier Buckeye program was not included in either the as introduced version of the budget or the as passed by the House version of the budget. However, the House did make some changes, continuing the council, but just having no funding for that. The House also extended the period in which the program can spend the allocations from this fiscal year due to kind of the late start of the program. The transportation budget also made that change, and so the House just reinforced that. Comprehensive Case Management and Employment Program was expanded to 14 and 16-year-olds. This would be about $84.1 million in fiscal year 18 and fiscal year 19. Step up to quality. There were some changes in the earmarks, not specifically funding, but changes to the earmarks, specifying $13 million in each fiscal year for the 2016 Ohio Child Care Market Rate Survey. This will help seek higher quality raters to more providers and to move more providers through fiscal year 2019. Requires that the in-demand jobs list to include an analysis of the jobs that pay a rate of 125% or more of the federal minimum wage. This is kind of helpful as we see a lot, as Lauren kind of touched on some of the changes around Medicaid and what that will really impact as far as waivers for individuals that are working or not. This will kind of help the state gauge where we're at on this. And additionally, the SNAP employment program, there was a $2 million increase in each fiscal year. This was also a part of the HOPES agenda, which Tara touched on earlier. And that is all I have, if there's any questions.
Thanks, Bree and Lauren. This is Tara again, and if anyone has any questions, please type those into the chat box. The next slide also includes our contact information, which I will turn to in a moment. Happy to take any questions via email, phone calls as the budget keeps moving through this process. Also, I mentioned earlier, but wanted to remind everyone to stay tuned for additional webinars on the budget. There will be one on the Senate-passed version of the budget in early to mid-June, depending on exactly when that final Senate version of the budget passes. And then look for another one later on in the summer as the final budget has been signed by the governor. We'll have kind of a really broad overview of everything and where it really ended up in the final version of the budget. So I will give everyone a couple more moments to submit any questions. Also, here is all of the information. If you want to get a hold of us, phone numbers, email addresses, also resources on our website. So we have a state budget resources page where, kind of all of the materials that we produce live. So that includes the state budgeting matters reports that we put out on each of these health and human service areas of the budget, as well as any testimony that we offer. We also try to keep up with blogs pretty regularly in terms of kind of, areas where we want to highlight some budget initiatives or really get information out there more quickly based on what we're hearing in committees and things like that. We also have a dedicated page for our Medicaid work, and so you see the link there for that, where everything related to what we produce on Medicaid and Medicaid-related topics. That's where all of that lives. There's also periodic events that we hold related to our Center for Medicaid Policy, and that registration information is always available on that Medicaid page. It doesn't look like anyone has any questions yet, but I'll leave this contact slide up for a few more moments so anyone can jot down email addresses and things to get a hold of us. Just to give you all a heads up too, we're looking to put out a blog this week related to kind of digging through that HOPES plan that will address the opiate epidemic, or the House plan to address the opiate epidemic. And then we're also going to produce state budgeting matters on kind of looking at all of these areas that we touched on in the webinar. So certainly information that can complement all of what we've covered in the webinar today. And I failed to include our Twitter handles on this page, but again, if you'd like to follow us on Twitter, that's at CCS Policy. And you'll be able to connect with many of us individually and the organization as well at Community Souls, SOLS, on Twitter. So if that looks like we are wrapped up, no questions in the chat box, but again, contact us if you need anything. Happy to answer questions, and thank you all for joining us today.